Hello, Afro DXs. Welcome to our first episode in the new series called Learning at Least One Thing. In this series, what we'll be doing is if we get some time, we'll make a video or some written teaching points in which we'll learn at least one thing for a day. If you've been following our channel, there is no video of a recorded video of the case that David discussed last week, and that's because we had technical difficulties. We couldn't record on that day, and we are sorry for that. So this first video will be dedicated to the teaching points related to what David discussed. I'll start by giving you a case, and after the case, pause and see what do you think on that case. So imagine you're seeing a 40-year-old male who came complaining of penile and body rash for 3 weeks. So he states that 3 weeks ago, 4 days after unprotected sex to a non-wife, he saw a bump on his penis, which was non-itchy, and later that bump ulcerated to form a painless ulcer. He went to before going to the hospital. So 2 days after that bump, he also saw body rash on the scalp, the face, the chest, the abdomen, and the thighs, even on the arms, and it involved the palms. So he went to the first hospital. He was tested for RPR, which was negative. He was given ceftriaxone sulbactam and mupirocin to apply on the rash, but there was no response. On the second week of the disease, he went to another hospital. Again, RPR was negative. He was given azithromycin and fusidic acid. And again, he said there was no response. So my hospital was the third hospital, and I saw this patient. I saw the painless ulcer, and I saw the rashes that were a combination of papules, and there was a nodule there. And on the palms, there was also like macules, hyperpigmented macules. I also tested RPR, which was negative, and other tests that I ran, they were negative. What do you think? What is the diagnosis here? And how are you going to treat this patient? Yeah, so I think many people get this right. I decided to treat this patient for syphilis despite a negative RPR. And that's why we have this teaching point so that we can learn why this happens. So you all know that syphilis is caused by Treponema pallidum and is transmitted through sexual intercourse to a infected partner. But if you touch the active lesions or kiss them, you can also get syphilis. Syphilis is staged into two stages, that is early syphilis and late syphilis. Early syphilis, in early syphilis, we have primary syphilis and secondary syphilis. Primary syphilis is just localized on the genitalia, like you have a painless chancre on the penis or on the vagina. Secondary syphilis is when you have penile chancre, painless chancre, plus systemic symptoms including rash. So this patient had secondary syphilis. Early syphilis occurs anywhere from weeks to months from acquisition of the disease, while late syphilis can occur anywhere from 1 year to 30 years from acquisition of the disease. The caveat here is patient with late syphilis, they must have had a primary syphilis before, but maybe they didn't see it because, it said painless ulcer. Someone doesn't see it, or they think it's just a papule there and it goes away. They say it goes away on its own, but it was syphilis. So late syphilis can be symptomatic or asymptomatic. If it is asymptomatic, you call it late latent syphilis. And if it's symptomatic, you can call it tertiary syphilis, or depending on where it is, CNS syphilis. In tertiary syphilis, you have things like um, syphilitic aortitis, in which there is dilatation of the aorta, or aortic valve regurgitation. But again, you can have the gumas, but these are very rare, like big lesions on the skin, bones, or internal organs. So of importance are the tests that we run in syphilis patients. And we have non-treponema tests that we all know, we all see them here, and the treponema tests. These are very important. So the non-treponema tests, these include VDRL, RPR, and a new test I saw, I've never used it, called TRUST. The treponema tests include things like FTA-ABS, TPPA, treponema pallidum enzyme immunoassay, etc., etc. So in testing syphilis, there are two algorithms. The first one is called the traditional algorithm that we all do it here and what's recommended by the WHO. So this algorithm is just which test do you start with? So in traditional algorithm, you start with the non-treponema test, as we did in this patient. So you send RPR or VDRL or TRUST. And if the result is negative, then it's either the patient doesn't have syphilis or they have syphilis, but it's a false negative. So if your clinical suspicion is high, treat them and tell them to come back after 2 to 4 weeks to retest for non-treponema test again. That's what we did in this patient. But if it is positive, then you send a treponema test. If the treponema test comes back positive, that patient has syphilis. If the treponema test comes back negative, that patient had a false positive. So that's the traditional algorithm. The reverse algorithm is the opposite of that. I won't go into it because I don't see why you should do that if you have this one, the first one, when it is cheaper. But what happened? Our patient had everything that pointed to syphilis, and then syphilis RPR came back negative. So two causes that can happen, and then you have a negative non-treponema test in a patient with syphilis. One is you have to understand what happens for the test to be positive. It's the antibodies that interact with the antigen, clumping occurs, and the clumping is what is called positive. So if the antibodies are not yet formed, it can be negative, but syphilis is there. Another thing is what is called the Prozone effect. So to understand the Prozone effect again, you have to know what happens for you to call a test positive. It's a clumping again. So if you have too many antibodies, these many antibodies can interfere with the clumping, and the clumping won't occur, and the test can be thought as negative, but really there is syphilis. To go around this problem is when your labs perform a titer of the non-treponema test. Many labs around here in Tanzania, including my lab, we do a qualitative. We say positive, negative, that's it. But what's recommended, what's in the literature, is a titer, a quantitative one that should be reported like 1:16, 1:32, something like that. So if your lab performs a quantitative, you tell the lab, I suspect this is syphilis, I suspect this can be a Prozone effect, and you please dilute the sample. So they will go into dilution higher and higher, and until at a certain point, if it was Prozone effect, it will become positive. Another advantage of having a quantitative test again is if you have the baseline titer from where the patient was when they had symptoms, when you treat them, you expect the titer to go down. So that's important. So after that, let's come to treatment of syphilis. So treatment depends on the stage of syphilis. Early syphilis, like in our patient, or in primary syphilis is start dose of methylpenicillin, of benzathine penicillin. So the dose is 2.4 million international unit IM start. For late syphilis, the dose will be 2.4 million units of benzathine penicillin once weekly for 3 weeks. And of importance, all sexual partners of the patient within the last 90 days should also be treated, because maybe they're also infected. So 2 other things which are important in this talk is, if you read the literature, you'll see something called early latent syphilis. I didn't talk about this. So early latent syphilis is when you have late syphilis, but it was acquired within the last 12 months. The patient is positive, they don't have symptoms, but they had syphilis within the last 12 months. The treatment is not different, but what's different is these patients will be considered infectious as opposed to late latent syphilis, in which they're considered not infectious, which means their partners also be treated. And then another is neurosyphilis. Neurosyphilis can occur anywhere in that spectrum. It can occur in early syphilis, can occur in late syphilis. So that's for today. See you later when we have another video. Thank you.